Hello, ladies and gentlemen. Welcome inside the broadcast booth. My name is Brian Wright, CEO of New Patient Group, national speaker, and the co-host of the Dr. Diamond Club podcast. A special welcome, as always, to our current clientele. As always, this webinar will be recorded and housed in your practice growth platform. I'd also like to welcome our outside guests today, joining us for part 2 of the Invisalign Sweet Spot cases by Dr. Regina Blevins. I can tell you, Dr. Blevins is not only a friend, she's an amazing clinician, and I am very honored to again call her a friend, but also a client. They've enjoyed very good success with our program and developed a great relationship, and really excited that she spends her time giving away some really great clinical advice to make sure your practices operate more efficiently. And the beauty part of this type of webinar is that she's covering all cases, whether it's an easier case, whether it's a very difficult case. That's what this ongoing webinar series of Invisalign Sweet Spot cases is all about. And she's going to talk about some really neat things today. I had the honor and pleasure of watching this webinar with her kind of before we're doing it today. And as we went through it, I was amazed just the little things that they do at their practice that you can pick up and take back to improve your efficiency, profitability. The list goes on and on. Is really, really good stuff. And I know with a combination of what we've been able to do for her and a combination of what they're already great at, you merge that together, and she has an amazing organization. And Dr. Blevins, with that, I'm going to let you take it away. Have a great webinar, and I hope everybody enjoys it. Please remember to keep all your microphones on mute. And Dr. Blevins, take it away.
Well, thank you, Brian, for those kind words. I'm excited to be back today to present another webinar for your group. We spent some time last time talking about sweet spot cases and how you can incorporate those into a busy practice and realize some of the efficiencies and profitabilities with utilizing clear aligner treatment. Now, today's webinar is a little bit of a different take on the same theme. I still want to talk to you about profitability because even though we want to help people and make and create beautiful smiles, if we can't do it and be profitable, we can't keep our practices open. So today I would like to dive a little deeper into some of the things that you can utilize to be more profitable and raise the bar a notch and talk about the profitability in treating some more moderately complex orthodontic cases. For those of you out there that have never met me, whether it's in the virtual world or in the real world, I'm Dr. Regina Blevins. I'm a graduate of the University of Michigan School of Dentistry and a graduate of the University of Minnesota's orthodontic program. I was certified to treat with Invisalign in the year 2000. So I've been doing it since just about the time it hit the market. I'm an associate professor at the University of Minnesota. I maintain a private practice here in the Twin Cities, and I'm a Diamond Plus Invisalign provider. I do want to tell you that when I present to you, these are my opinions. They're the way I treat my cases. Align has not told me what to say or what to endorse as far as protocols. What you see is what I did. So with that out of the way, let's dive in. A little bit more about me as a person, not a professional. I'm a working mom. I have 4 wonderful kids, and I'm also married to an orthodontist, Dr. Tom. We don't practice together, mostly because we want to stay married. But seriously, I can empathize with families and working professionals trying to juggle appointments and family life and work balance. And so with that in mind, I want to talk to you a little bit about the efficiencies in your practice. There are some key things that will drive your profitability. An obvious one, and one that we often think of first, is reducing costs. But in my experience, you can only reduce costs so much, and then it starts affecting the quality of what you do. You can reduce costs by eliminating employees, but only to a certain level. You can reduce costs by using the cheapest materials, but only to a certain level. And then it starts affecting the quality of what you do. You can increase patient volume. Well, again, you can only do that to a point, and then it starts affecting what you do and the quality of the product that you produce. And then you can introduce new products and services. So one of the things our practice has tried to capitalize on is introducing a new treatment modality. And in our practice, it's been Invisalign clear aligner treatment. And what we've found is with that kind of treatment modality, we can introduce some efficiencies that weren't available to us with our fixed bracket and wire patients. And then last but not least, you can make every procedure in your practice more efficient. And that's where working with Brian and Eric at New Patient Group has really helped our practice. So we can be more efficient on the phone and maintain the same quality of conversion or even better conversion. Maintain the same quality in the clinic, but be more efficient in our procedures and shorten our chair time when we're working on our patients. So let's look at some of this a little more closely. The first thing I want to talk to you about is what I'm going to call a practical efficiency. At least for Invisalign clear aligner therapy, the aligners come packaged in a box. And there's 11 aligners in the first box and an attachment template. And in subsequent boxes, there's 12 aligners. So one of the things that we sat down and talked about in our practice group was really how often do we need to see our clear aligner treatment patients. And we started out seeing them every 8 weeks and found that really at the appointments we were spending maybe about 5 minutes doing a fit assessment. If we were doing IPR, maybe a bit longer, not much. And what all of the doctors that I work with, there's 4 doctors in our practice, we all agreed that 8 weeks was too often. So then we stretched it out to 10 weeks and still found that the majority of the patients could have probably skipped that appointment. They were doing very well. So looking at the packaging, and this is where the packaging of Align clear aligners comes in, we decided that we would see our patients based on how the aligners were packaged in the box. So now our protocol is to see our patients at their first visit. Of course, we do the new patient exam and we spend about 60 minutes on that because we want to do a one-step consult, getting all the records, presenting finances, and we're finding that we have about a 60% conversion rate when we do that, which is up for us from what it was before we started that. And then we do our initial delivery and we allow about 50 minutes for that appointment. But we've capitalized on an efficiency with that by only having the patient in the chair approximately 20 minutes to put their attachments on. Now, sometimes we can do it in 15 minutes. Sometimes it takes 25 minutes. But on average, we're working on doing attachments for about 20 minutes. Now, why are they in the office 50 minutes then? Well, before they come back to the chair, and this is one thing that the new patient group has helped us develop, before they come back to the treatment chair, they're watching a video on an iPad. And on this video is wear and care instructions for how to take care of their aligners, how to insert them, how often they should change them, and troubleshooting things. Now, this is a video that we shot in our office with an iPhone, almost homespun feeling, and I like that. It's personal. But what I really like about it is after we get done putting attachments on, really all we have to do is make sure that the patient can take in and out their aligners, and we actually get them up out of the chair and take them to the brushing sink, and that's how where they're coached on taking them in and out. And then once they can take them in and out, our assistants ask them, is there any other questions or anything else that you didn't understand from the video? And if they say, well, I don't remember it all, we tell them that, of course, we're going to send them a link to it, and they can watch it again at their leisure at home anytime they want more information. So the cool thing about that is it reassures the patient that they have access to this information. They have access to it at their leisure without having to call us. And they're not as likely to spend time in the clinic, in the treatment chair, asking questions that they know that they have access to the answers later. So that's our initial delivery appointment. And then at subsequent visits, we do what we call aligner fit assessments. And typically they're in the office. We tell them to plan about 20 minutes for each visit. And they're typically in our treatment chair for about 10 minutes. The rest of the time, we spend visiting with them a little bit, in and out, and personalizing our service. But each time we have them bring their next box of aligners, which typically has 12 aligners in them. Okay, so at the very beginning, at the initial delivery, we send all their aligners home. Okay, but we ask them to bring the next box to each subsequent appointment. So on average, we probably see our patients about 4 to 6 appointments for fit assessments. And then we have a visit where we take the attachments off and go from there. So as you can see, seeing the patients every 12 weeks is very efficient. It makes sense with the packaging. And we've told the patients certainly that they can get a hold of us if something stops fitting in the meantime. But the vast majority of patients, this works very well for. So our mindset had to change from doing what was needed for the outlier patient that might need to be seen more often, and we can make different accommodations for that patient, versus seeing the patients less often, which worked for the majority of our patients. Okay, so we're on 12-week intervals now, and it seems to work for our practice really well. So let's look at our first patient. Carolyn is a 31-year-old female who has a chief complaint that her orthodontic treatment has relapsed, and she has a recurrent open bite. She's had her braces as a teenager, and like many in her age group, stopped wearing her retainer and has had this relapse happen. And at this point, her dentist and another orthodontist has told her that the only option for her is jaw surgery. During her treatment, we found her compliance to be excellent. She was a highly motivated patient, a pleasure to work with. But here are her extraoral photos and her intraoral photos, and you can see the relapse that she's had, a relapse in the open bite and a relapse in the anterior crowding. And looking at her x-rays, you can see that that's confirmed. And her Ceph measurements tell us that she's got a little bit of a class 3 tendency and a bit of a steep mandibular plane. So our diagnosis for her is a class 3, class dental and skeletal malocclusion with some mandibular excess, an anterior open bite. She is in the permanent dentition with a protrusive mandible and a vertical growth pattern. You know, with this open bite, you have to highly suspect a tongue thrust habit, and indeed that is what she had. And then along with the crowding, she has had one tooth extracted, tooth number 21. So our clinical goals and our strategies here, we're going to try to broaden her arch, enhance her aesthetics. We're going to work with her on some tongue thrusting exercises for control of the habit. And one of the things that we did explain to her is that we might have a little bit of a limitation because her problem was skeletal, not just dental. We're going to treat her with Invisalign clear aligners and some interproximal enamel reduction and elastics for her class 3 correction. So let's take a look at her ClinCheck. The blue dots indicate movements that may be less predictable. And as you can see, it's a combination in her case of anterior extrusion and posterior intrusion. We have optimized root control attachments in some of the bicuspid areas, optimized extrusion attachments in the anteriors. And we're running the class 3 elastics. Now, my elastic size that I use is a 2.5 ounce 5/16 elastics, and that's typically what I start with. If that doesn't seem to be enough, then I will next go to a 4.5 ounce elastic. But here is what we're predicting to happen. And the keys for this ClinCheck from the one that they originally sent me and the one that I approved, I slowed it down. I thought 24 stages was too fast, and I added IPR. Okay, so the attachments I liked. I didn't change that. And here's her 6-month progress photos. And you can see that her open bite is starting to close down. And her extraoral photos at her final, you can see that we've corrected her anterior open bite. Okay. Looking at her Ceph, we've seen some nice improvement with that open bite as well. So comparing her intraoral and photographs, the before and after, I think this is a nice touch-up for her. Nice arch form change, and the crowding has been resolved. Looking at her digital scan comparison, you can see that our findings in our photos are confirmed. So in summary, the treatment time for her correction was about 11 months. We used 50 stages of aligners. We saw her, even in a case that's reasonably complex like this, she was in our office for 7 active visits. We charged $55.08 for her treatment. At our level of provider for Invisalign, our lab fee was $1,000. In parentheses would be their other level of lab fee if you didn't get any discount. And for our level of discount, we realized a profit of $644 a visit. And that translated to about $2,000 or $3,000 an hour for my lab fee, and about $2,400 an hour if you're paying the maximum lab fee. So even a case like this, I think you can do an adult treatment like this with very good profitability, as long as you aren't micromanaging it and seeing the patient too often. And trust me, they're busy. They don't want to come in too often. But let's look at our next patient. This is Tessa. She's a 15-year-old female, and her chief complaint is just crowding and alignment. Her dad had been a patient of ours, and Tressa did not want braces, okay? She was a great patient, and here are her extraoral photos. And as you can see, she is a full step class 2 with a deep bite and some anterior crowding. Now, in fixed brackets and wires, this would probably be, in my practice, a 20-month case at least. And looking at her Ceph, it confirms that she is class 2, and she has a class 2 Div 2 relationship. She is in the permanent dentition and has a bit of a retrusive mandible. When her teeth are aligned, she will have excess overjet. Right now, also, she has an impinging overbite and a moderate amount of crowding. She's also starting to have wear on her anterior teeth. So our clinical goals for her are the arch development, improving her alignment, trying to use some elastics for growth modification, improve her aesthetics, and overbite and overjet correction. So we're going to use, again, Invisalign clear aligners with some interproximal enamel reduction and the elastics for the AP correction. So let's look at her first ClinCheck. Okay, you can see the intrusion that we're going to program in. She has class 2 elastics she's running, and I don't have IPR, didn't come up in the first ClinCheck, and I want to take a look at her attachments. I see deep bite protocol attachments have been populated on the bottom, but I don't see any attachments to reinforce the anterior intrusion. So this is her approved ClinCheck. And I've added an attachment for anchorage on the lateral incisor and to help with the rotation, okay? There we go. And after looking at her Bolton analysis, I elected to defer the interproximal reduction. So the key to this ClinCheck is anchorage for the incisor intrusion and some time for the elastics to work. So for this particular patient, I had 2 options. I could double the number of aligners, or I could leave it at the rate of what it came back at and have her wear them 2 weeks. And in this particular case, I let her wear them 2 weeks each. So here she is with her extraoral progress photos. And here she is at 17 months. Okay. So looking much better. And I did a revision ClinCheck for her, where I did add a little IPR to help with her rotation and to settle her posterior bite. So I've added new attachments where I've needed help with rotations and anchorage for extrusion and settling the bite. And I'm also improving her anterior torque. and finessing the bite on the bottom and axial inclination. So here are her final extraoral photos, and she's settled in quite nicely. Now, as you can see, this one first molar over here is still a little out of occlusion. And if that happens to you, and one of the reasons I put this case in is I want you to know how to troubleshoot that. I simply cut the aligner off at the posterior and let them wear them for a few weeks, and that typically will settle right in. So here's her comparison of her beginning intraoral photos and her final extraoral photos. And as you can see, we've met our goals. Looking at her intraoral scans, another thing that I really like about aligner therapy is if I look at my final, even though I'm done essentially with most of the treatment, if I see something going on with second molars, I'm not locked into saying that she's completely finished, and I can do a touch-up on that. And here we have her before profile, and you can see how much she's improved in the final photo. So where we're at with her at this point at 24 months, okay, very similar to what I would do in fixed, is a profitability of about $430 a visit. Whoop, let me go back, I'm sorry. Where we are with her at 24 months treatment time, very similar to what I would do with fixed, is at a profitability of about $430 a visit and about $1,800 an hour. Okay. Now I'm going to see her because we're finishing her up now for a few more visits and get the second molars socked in. But as you can see, even a case like this where you've got a full step class 2 and treating it with clear aligners, in my hands, it's just as profitable as if I were treating it with fixed appliances, because these same things happen with fixed appliances. I have to tweak the second molars and they come in for a few more visits. But these visits are much easier for me than the visits when you're keeping a teenager like this who doesn't want to be in braces anymore hostage. And I think that this is a better practice builder in our office. So I'm going to introduce you to Liang. He's an adult male with a chief complaint that his teeth are crowded. He did also have braces in China, but did not get total correction. So here are his extraoral photos. And as you can see, he is quite narrow and quite crowded. And looking at his x-ray, he comes to me with some limitations, okay? So we're going to have a hand tied behind our back with this case because on one side he has a bridge and on the other side he has an implant. He's a little class 3 skeletal, and he has a very low mandibular plane angle. So his diagnosis is class 1 malocclusion with some mid-arch narrowing. He is a clincher. He's got a moderate amount of crowding, maybe severe even on the lower arch, and he has that implant and the bridge. He also has some jaw popping. So on our clinical goals, we're going to look at enhancing his aesthetics by resolving his crowding. We're going to use Invisalign aligners and some interproximal reduction. And this is a case where my interproximal reduction is a bit more aggressive than some cases that I do, but still well within the realm of being clinically safe. Okay, so what I like about aligner therapy in a case like this is, one, I don't have to worry about bonding brackets to porcelain, and I can tell Align and program into my ClinChecks not to move the teeth that have the bridge or the implant, which is much easier for me to do than when I'm trying to account for that with brackets and wires, okay? So I can do some proclination, I can do some expansion in the first bicuspid canine area, and still control this case. But again, probably the key here is doing the IPR that you actually program in, and don't shortchange that. So that was the ClinCheck. We did some minor modifications to the original ClinCheck. And I did a little more expansion in the anterior and a little bit less IPR. But the beauty is, whatever your comfort zone is with that, you can adjust that yourself. So here he is at his 6-month progress. And we're going to do a slight revision just to overcorrect some of those anterior rotations. Okay, see that? Overcorrecting the anterior rotations. Okay. And resolving some minor rotation on the bottom by overcorrecting that as well. Now here is his intraoral progress photos, and you can see at 7 months we have some correction, and at his final photos you can see that we've met his goals and resolved his issues. So here is his extraoral before and after profile and Ceph. We did have some improvement in his A and B, and a slight change, probably not statistically significant, in his mandibular plane angle. So comparing his intraoral photos, you can see what nice improvement he's had. And really, in my hands, I didn't have to worry about any of the tension or pressure on either his implant or his bridge. And looking at the comparison of his intraoral scan, you can see that we've maintained his occlusion quite nicely. So in summary for him, his total treatment time was 10 months. We had 32 aligners in his original ClinCheck and 8 aligners in his revision for that overcorrection. We saw him for 7 visits and realized a profitability of about $640 a visit, or $3,000 an hour. So one last thing I want to leave you with is the thought of tele-dentistry. And this is one of the things that our office is starting to work with now, because we have quite a pool of patients that have either relocated or they've heard about us from somewhere, and they're being treated from a distance, not close to Minneapolis, St. Paul. They may live in Chicago. We have a patient in Shanghai. I have a patient that's in Africa. We have a lot of college students because they want to be treated during the school year with us, but during the summer, they're back home with their families. So I want you to think out, not just outside the box, but like there is no box. So some of our fit assessment visits, we've been utilizing cell phone photos for those assessments, and the patient hasn't even come into the office. And that has worked so well that some of the adults in our regular practice setting, we're offering the 12-week visit. We'll see them initially, and then the first 12-week visit back. So that would be like at week 24, we're offering them to do a tele-dentistry visit where we have shown them how to take a lateral view photos and anterior view photos, and we can tell them if they should come to the office or if they can proceed to the next group of aligners without even coming in. And we do this via email, and so far it's working quite well. So our adult patients, we have a pool that we're testing where we're really only having them in the office every 24 weeks. So I just want to kind of leave you with that idea. And the final thought of, just like gasoline powered cars may someday be a thing of the past, we're looking at now coming in to see the orthodontist. Certainly early on in my career, everyone saw patients every 4 weeks. But now it's quite common to see patients at 10-week intervals. And we may see a time where we use tele-dentistry and we see our patients certainly at the beginning, certainly at the end, and maybe one visit in the middle. And that's a win-win. It's an efficiency for us. Will certainly help with our profitability and being able to see more patients and increase our volume. But it's a win for the patient too, from their schedule and their time, family balance, and budgeting their time as well. So I thank you for tuning in. I hope this was helpful and that you enjoyed the presentation. And I look forward to talking with you again in the next quarter.
Well, I want to thank you, Dr. Blevins. That was fantastic. And how many of you out there listening right now are scared of the tele-dentistry? That is the kind of stuff that the New Patient Group and our Advanced Study Club, the Diamond Club, and our clientele are doing things that are out of the box, innovative, and the consumer absolutely loves it. Now, for some of you out there, that could scare you. But the facts are, it's the Blockbuster Netflix theory. Blockbuster was on top at one time in this world, and we all know the story. They no longer exist. Change with the times. You are in a consumer-centric business, competitive marketplace. Consumers have options, whether it's your practice or whether or not they want to go spend their disposable income on something else other than dentistry or orthodontics. You got to think outside the box. So a lot of the things that Dr. Blevins talked about, I absolutely love it. And a lot of those things we work on with our program. So great stuff, Dr. Blevins. We really appreciate your time. I hope everybody got a lot of it out there from everything she talked about today. And if you want to learn more about New Patient Group, just visit us at newpatientgroup.com. And we're actually launching a new website in the near future that's going to have a lot of really cool stuff on it. Huge upgrade that we're working on. It's been in the works now for, 6-8 months. So excited about that. Remember to subscribe to our YouTube station, New Patient Group. Just type that in and subscribe. And then also remember to subscribe to our podcast. I have a national podcast. A lot of people get a lot out of it. We have a lot of great guests. Just a lot of good information that we give away. So again, to our current clientele, we appreciate your continued partnership and your trust in allowing us to grow your organization in a multitude of ways. And all the guests that joined us today, appreciate your time. Looking forward to helping you as well. You guys have a great upcoming weekend. Talk to everybody soon.